have been added to the juxtacortical lesion as a determination for dissemination in space. So, although the MRI alone cannot be used to diagnose MS, it remains the imaging procedure of choice for confirming MS and monitoring disease progression in the brain and the spinal cord. MRI is not specific, but it is considered the most sensitive imaging modality for diagnosing spinal cord MS, for evaluating its extent, and for following up the response to treatment. In order to go deeper within the MRI, I see it very useful to go within the geography and the topography of those MS lesions that we see within the MRI. So what are those lesions and how those lesions are presented, where is those lesions, and when their value will be important. Let's go through the MS lesion in terms of pathology. So there are 4 types defined as the basis of MS lesions. So myelin protein loss, geography and extension of plaques, patterns of oligodendrocyte destructions, and also immunopathological evidence of complement activation. And recently, the MS pathology, including macrophage infiltration and abnormal iron deposition, have become quantifiable within those lesions. Now, again, within the pathology, the MS starts as an inflammation around the perivenular veins. In the first 4 weeks of the inflammation, there is an enhancement with the GAD due to local interruption of the blood-brain barrier, homogeneous that can change to be a ring open enhancement. Inflammatory cortical demyelination is present early in MS. Meningeal inflammation may drive a cortical and white matter injury in some MS patients. Now, in regards to the topography, has a typical distribution within the white matter lesions. The typical for MS involvement are periventricular lesions abutting the ventricles, juxtacortical lesions abutting the cortex, involvement of the corpus callosum, involvement of the temporal lobes, and brainstem, cerebellum, and the spinal cord. Again, when we go deeper into the periventricular itself, between 2016 and 2017, there was a lot of paper talking about those lesions by itself, and they proposed some modification within the MS diagnostic criteria, such as increase in the periventricular lesions from 1 or more up to 3 or more. Inclusion of cortical, optic nerve, and symptomatic lesions within dissemination in space. In 2017, Arambide and her colleagues, they started to say, well, we will maintain the current 1 lesion and more as a cutoff of McDonald's criteria, which does not compromise the specificity of the typical CIS cases, attention to the older age or cases of optic neuritis, and combining the cortical and juxtacortical with one name called corticojuxtacortical lesion. In terms of the topography as well, now the periventricular MS lesions and the SWI, they were talking about the iron deposition and all of that. So the potential target for differential diagnosis of white matter lesions, the periventricular distribution pattern, and the suggested increase in the iron deposition within the MS-related lesions. And that's why the SWI, or the susceptibility weighted images, is a high sensitivity for detecting the iron-containing tissue and the small veins. And a diagnostic value when co-registered and mixed with the standard pulse sequence, such as the T2 weighted image and the FLAIR. A chronic focal MS lesions and some acute focal lesions can be depicted as an area of low signal intensity. These hypointensities probably represent free radicals or iron deposition, and the presence of central vein sign is not a specific radiographic sign for the MS. In the term of the cortical MS lesion, it can be identified using non-conventional MR, which is the DIR. It was proposed as part of the dissemination in space criteria, but unfortunately the inter-observer variability was high, and combining the cortical and juxtacortical were now as a single term called corticojuxtacortical lesions. That was the topography. Now, how about the morphology of those lesions? Ovoid lesions perpendicular to the ventricle, forming the Downson finger, enhancing lesions, black hole representing axonal loss, all of that are typical for the MS lesion. What are those diagnostic implications with the MRI itself? Now, generally, we should all know that a serial MRI in the diagnostic workup will help a lot and have a lot of values. In terms of radiological isolated syndrome, for instance, a new active lesions in patients with radiological isolated syndrome increase the risk of subsequent MS clinical event. In radiological isolated syndrome, a follow-up of the brain scan from 3 to 6 months after the initial MRI is also recommended. In terms of clinical isolated syndrome, who have at least 3 white matter lesions at baseline will develop a new T2 lesions over the subsequent 3 months. And if no new lesions are seen at the follow-up scan, a third scan can be acquired from 6 to 12 months. So the serial imaging will be helpful in terms of cases like RIS and CIS. Another implication important for the MRI is in the prognosis of the disease, right? So in terms of CIS, whenever there is a high T2 lesion load, there will be a risk of definite MS after a diagnosis with CIS. This is a 20-year follow-up. In CIS with normal baseline MRI, they do not convert, and this is again a 20-year follow-up. Now, when we say CIS with normal baseline MRI, we mean maybe optic neuritis, maybe the patient have just a spinal cord lesion with a clear brain. In optic neuritis trial, high baseline lesion number converted to definite MS, and the T2 lesion number also have an implication with the disability accumulation. So those are the values that we can take over as a messages from those lesions within the MRI. Now, also again, within the disease prognosis, one lesion in the cerebellar lesion is related to an elevated conversion rate to definite MS, right? One brainstem lesion associated with a higher risk of conversion and increase the disability accumulation. 2 lesions in the infratentorial, such as cases in CIS, seems to have high predictive value for a long-term disability. So generally, the relevance of infratentorial lesions in relation to clinical outcome, spinal cord lesion, infratentorial lesion, and contrast-enhancing lesions in optic neuritis have a predictive value for disability accumulation within a 6-year follow-up. What about the global brain volume changes and the brain volume loss? Now, assessment of brain volume does not have a role in the diagnostic processes with MS, but can be a good predictor for a long-term disability. Now, measures of the brain volume can be used in clinical studies and as an endpoint in a clinical trial, but confounding factors like a pseudo atrophy should be taken into account, especially with some pharmacological effect. Now, rates of changes in the brain volume are not recommended as a marker of disease progression in individual patients, owing the technical, biological, and pharmacological factors that can influence the measurement and the interpretation of those atrophy that we see. The use of advanced MRI methods for MS disease monitor is promising, but has not been well investigated. So their value is potentially limited due to lack of standardization. Now, in 2017 revision of the McDonald's criteria on MS diagnosis reinforced on the importance of brain and spinal cord MRI examination. 2017 revisions also emphasize the strong need for strict standardization of the MRI acquisition and the interpretation to avoid misdiagnosis. So the need for standardized brain and spinal cord MRI acquisition and reporting at the time of the first clinical presentation and during the early course of MS goes beyond the diagnostic purposes, since it provides important prognostic information. And we all sense that during, as a clinician, of course, during the follow-up, and sometimes when the patient presented as a second opinion, all what we ask for, apart from the examination, is asking for the serial MRI that the patient has been going through, right? So in 2021, the Magnums and the Consortium MS with the names, they have a consensus recommendation for the use of MRI establishing the MS diagnosis. And their standardized initial brain protocol was at least 1.5 to 3 Tesla should be available, and the acquisition and interpretation for clinical in routine purposes require dedicated expertise. The core sequence is T2 weighted images and the T2 flare image plus the axial T2 and the T1 weighted with gadolinium. So those are the fundamental sequences that we need to standardize all over. And I always say MS neurologist and the MS radiologist should have the same language when they are working together. So the recommendation for the use of MRI establishing the diagnosis that we just mentioned in the protocol has been done, but the follow-up imaging is also important. So when the first MRI does not fulfill the criteria, the brain MRI is recommended every 6 to 12 months in clinical isolated syndrome and subclinical multiple sclerosis, radiological isolated syndrome with risk factors of conversion to MS and paraclinical features such as positive oligoclonal band. So those are like a timing issue when we want to just follow up those cases. Spinal cord MRI is not routinely recommended. The use of gadolinium in the follow-up. The use of gadolinium is not recommended. The identical image acquisition, standardized repositioning, field strength, pulse sequences, spatial resolution is strongly recommended. Now, how about the spinal cord? The use of MRI within the spinal cord in the diagnosis of CIS. So establishing the diagnosis is important. Detection of symptomatic and asymptomatic spinal cord lesions to show dissemination in space and time. And also CIS syndrome with differential diagnosis in case of inconclusive brain MRI findings. So presence of atypical demyelinating spinal cord lesion. We need to exclude alternative diagnosis such as the neuromyelitis optica or the MOGAD. In the primary progressive MS, in establishing the diagnosis of PPMS, detection of typical demyelinating spinal cord lesions showing the dissemination in space, detection of diffuse lesions again, and also exclusion of any other alternatives. Their recommendation as well for the use of MRI in the prognosis and monitor of the spinal cord. So in the prognosis, the radiological isolated syndrome, it will help in prediction the CIS. And in the clinical isolated syndrome or early MS, it will predict the disability and the disability progression and the development of secondary progressive MS. And those are about the prognosis. And how about the monitor? Now, patients with MS and spinal cord phenotypes, sometimes they have an active spinal cord lesion. So we need to detect that in terms of monitor. And patient with MS and disability worsening that cannot be explained with the MRI of the brain. So detection of active spinal cord lesions and exclusion of other comorbidity within the spinal cord is also needed. Patients with multiple sclerosis and repeated spinal cord and relapses, so detection of active cord lesions is important. Exclusion of any alternative causes also here is important. Again, we can use the spinal cord images when we do a treatment switch, or we need to have sharing the decision with the patient that we need to escalate your therapy. So we need to detect if there is any active lesions within the spinal cord. So the third thing is the atypical spinal cord relapses or atypical spinal cord symptoms or signs suggestive of comorbidities. Again, in those aspects, the recommendation supports the use of spinal cord MRI. Now, how about the use of MRI for monitor the treatment effectiveness and assessment of disease activity? MRI timing is important. So obtain the baseline MRI with gadolinium. This is one. Obtain a new baseline brain MRI, usually 3 to 6 months after treatment. Usually, in most of the cases that I treat, 6 months is a good limit after starting the medication. Obtain a new baseline MRI usually 3 to 6 months after the treatment initiation without gadolinium, unless there is a high active disease. Consider gadolinium enhanced MRI on the first follow-up scan after treatment initiation in the absence of new baseline scan, and obtain a yearly brain MRI while the patient is on disease-modifying therapy, and in such cases, consider a longer interval in clinically stable patient. In patients who show MRI disease activity that is not associated with clinical activity on a follow-up scan, consider a new MRI scan without gadolinium 6 months later. So usually the 3 to 6 months and then an annual MRI is important. And again, simply the first baseline MRI should be with gadolinium, and the annual should be with gadolinium the first year, and then later on we can manage without giving the gadolinium. Unless, of course, if you are thinking that your patient is highly active. Again, at the end, this is a consensus recommendation. Your input with your patient is also important. So the use of gadolinium-based contrast agent in diagnosis and monitor of the MS. The use of gadolinium enhancement recommended to show dissemination in time, to contribute in the differential diagnosis, to predict the future disease activity, and to some extent disease progression for a phenotyping patient with progressive disease, like active or inactive, recent within the last 6 months or more than a year. So this is also important when we use the gadolinium. Now, in terms of monitor, as I just mentioned, the first year follow-up is needed to be with contrast. If detection or confirmation of clinical disease activity is required in patient without a recent reference brain MRI, like you receive this patient new and there is not the patient is new, but second opinion, but the patient for a while doesn't make any MRI, so re-baselining is important. And again, here also, if we want to detect diffuse or confluent chronic multiple sclerosis, like large lesion burden, and also for the PML cases for screening, and also for monitor of the PML. Those are the recommendation for the use of the gadolinium. Now, when not to use the gadolinium? To show dissemination in time on serial MRI scan in case of standard monitor for subclinical disease activity. It's not recommended. A new baseline, usually 3 to 6 months after treatment initiation. So you already started the treatment. A new baselining is not needed in such a case. You already diagnosed, you already initiate your therapy, you just need a follow-up monitor. In short follow-up MRI, again, within 6 months, done to confirm the disease activity in patient with isolated MRI activity on the previous MRI scan, and for PML screening and during the pregnancy. It's strictly contraindicated. How about the use of pregnancy and during postpartum lactation? MRI is not strictly contraindicated during pregnancy. However, the need for MRI during pregnancy should be assessed on a case-by-case basis. Clinical presentation that's suggestive of unexpected disease activity or comorbidity such as cerebral venous thrombosis. Again, those are recommendations, and you need to have your clinician input into your case. You know your case better. So the use of standardized protocol, as I just mentioned in the beginning, gadolinium-based contrast agent during pregnancy are again contraindicated. New or enlarged T2 lesion can be used for detection of disease activity. In terms of postpartum, there is no limitation to use of MRI in the postpartum phase. MRI acquisition should be done according to the standardized protocol. The administration of gadolinium-based contrast agent during lactation should be allowed only if highly necessary for diagnostic or monitoring purposes. But if the macro cyclic gadolinium-based contrast agent are given, then it might be possible to continue breastfeeding as it doesn't pass to the milk to the baby. Active T2 lesions like new or enlarged lesions are the preferred measures for inflammatory disease activity, and a new baseline MRI after pregnancy 2 to 3 months postpartum is recommended. Especially in active cases, like patient who got pregnant while her disease is active, and then after she delivered postpartum, you need to do the MRI 2 to 3 months. But if her disease were stable before, this is not recommended. Now, again, also for the monitor treatment and the safety, such as in Tysabri or in natalizumab, looking for the PML is also one of the indication to use the MRI. Obtain the annual MRI according to the standardized protocol, do frequent PML screening every 3 to 4 months with an abbreviated MRI protocol, which is the FLAIR, T2, and diffusion weighted images exclusively for patients who are treated with natalizumab and have a high risk of PML occurrence, like a seropositive GC virus. By this slide, I reached to the end of sharing the information with you. Again, I would like to thank everyone and see you soon.
Hello, Dr. Rumaiza. You can hear us?
Yes, I can hear you. Hi, everyone.
Dr. Rumaiza, thank you so much for excellent presentation. Definitely.
Thank you, Dr. Rumaiza, for an excellent presentation on the diagnosis and on the especially MRI diagnostic criteria and McDonald's criteria. So if we have any questions from the audience, we can take few.
Yeah, sure. It will be my pleasure.
So, Dr. Rumaiza, what do you recommend in suspected patients of PML? Do you recommend MRI with contrast or just a simple annual MRI without contrast is still suffice?
Yeah, well, actually, in terms of suspected cases, like you have your clinical data, all of that, then I would recommend, yes, in the beginning, I recommend to do the MRI with contrast. Now, usually, in the center that I work in, which is my clinic, what we do is doing a package that whenever I suspected a cases of MS, we'll do the brain, cervical, and also the dorsal or the thoracic. So we'll do the whole axis, of course, including some with contrast, including the blood test, the autoimmune profile, and also including the visual evoked potential. So generally, in terms of MRI, I would recommend the baseline will be with contrast.
Okay, Dr. Rumaiza, I want to ask you a question. Like, we have a lot of young women who have MS and they are on treatment. So the only disease-modifying treatment available in Pakistan is teriflunomide and ocrelizumab. Now, if they want to become pregnant, so what would be your advice to them? Especially, for example, they are planning like a pregnancy after 6 months. So how they could quit medication, how long they quit medication, and what is the risk if they quit taking medications, because they have been stable for a few years, but they're still not out of the woods. So what would you recommend them, and and how would you restart them after the pregnancy is over, especially during the breastfeeding period? So what is your recommendation would be?
Yes, thank you for this question, because this is exactly what we face in Saudi Arabia. Now, in general, as long as we have the biological agent as an option in Pakistan, well, I would go for the biologics in terms of ladies who planning to get pregnant, or even impending or future, like she's 20 and at those kind of age, she might get married and she want to get her family bigger. So I would recommend going to biologics instead of the teriflunomide. Now, in general, we know that we need to wash out some of medications, and we have a period of those wash out, and we need also to measure sometimes the level of the drug. Now, in general, the biological agent I would recommend to go for biologic. However, when we start the biologic, we discuss with the patient. Now, the aim is to be disease activity free, right? So we want the patient to be free of any disease activity. So once she diagnosed, her disease is active, and we need to stabilize it for 1 year. This is what I tell all my patients. Just be patient with us for the first year. It's the key to start the future. Now, after the 12 months, if everything is stable, and I mean, in that term, if she wants to increase her family or something, we recommend that she will hold on that plan until we finish the year. Now, after we finish the year and we decided together that her disease is stable, then this is the time where she can get pregnant. But the idea in that, after she took her last dose, she will wait for 6 months, right? And she's due for the third dose, for example, ocrelizumab. Now, she will not take that third dose, and she has 6 months really to plan for her pregnancy without pressure. Now, after she get pregnant and she delivered, she also decide for how long she want to get the lactation period, right? So some of the patient months, some of the patients she want to complete a year. We also supporting the breastfeeding and all of that stuff. So once she's stable and she finished all of that, we can resume her medication. Now, in that kind of period, if she get pregnant where her disease is active, and after she delivered, we recommend from 3 to 4 months to do the MRI, right? Even if she has no clinical symptoms. We are not waiting for a clinical attack. If her disease before pregnancy were active, if her disease before pregnancy were stable, then I would recommend not to do any, no rush to do any further imaging postpartum.
Okay. Any more questions? Sarmad has a question.
Hello, Dr. Rumaiza. An excellent talk. I would like to ask how frequent you do the MRI in radiologic isolated syndromes?
Right. In radiological isolated, first of all, those kind of cases are the diagnosis, either their family having MS and they come to do the images and we found those typical lesions, but they don't have any clinical, or accidentally we find the typical lesions while the patient having migraine or anything else. So on those cases, all over the world, no one will decide to treat, right? So we are just following by imaging. Now, as the recommendation we were mentioning, 6 months is in the first year. So we diagnosed, like we labeled the patient as radiological isolated, and then we'll do in a 6 month duration. Later on, if there is no change, then we could make it annual for the first 2 years, and then we postponed it more and more. So after the annual for 2 years, nothing increased, then we'll do it 3 years, then 4 and 5 and so on. So generally, this is the start. Now, some of the cases will sneaky shift into CIS. So we need really also as a clinician to be vigilant, right? So some of the patient will go into optic neuritis, okay? And the optic neuritis, not they sleep and get blind on the second day. No, but optic neuritis, like those blurry vision for 3-4 days, and we need to document that by the visual evoked potential or the oligoclonal band in the CSF. So we'll not go through that details unless we have some clinical attack that we document. So the patient should be vigilant, the clinician should be vigilant, but as an answer to your question, the first year, 6 months, and then annually for 2 years, and then we increase spacing out more and more.
How will you compare the modalities like visual evoked potential versus OCT, optic nerve? But I have the feeling that OCT is relatively more specific for optic neuritis rather than visual evoked potential. What do you
Yes.
say about?
Yes, you're absolutely right. Now, those are in the latest ECTRIM in Amsterdam. Those were the debates. Now, OCT, nobody will debate on like the value of it or the importance of it. Now, all the talk were about the orbital and the necessity to do the orbital MRI and the necessity to do the visual evoked potential. Before they were downgrading the importance of the VEP, but in the latest ECTRIMs, they were really talking a lot about how important also the numeration or increasing in the data that we got. So more parameters, more information we got, and more later on reaching to early diagnosis. So the whole idea of that is to detect early and to treat early. However, we don't want overdiagnosed, of course. That's why it's until now still the optic neuritis is not within in the recommended criteria. But yeah, for me in my clinic, I refer patient to ophthalmologist. I don't do the OCT myself. However, the center that I was trained in, they have the OCT in their center, and the neurologists will do it. They were trained for that. But for me, I don't do it. I send it to my colleague in the same center. But in the neurophysiology section, yes, we do the visual evoked potential. And as I told you, I put it especially in the patient with CIS in the package of collecting all the information in patients suspected with early MS.
Now we have a question from our virtual participant, Dr. Shaista posted a question that if someone is now during pregnancy and someone is off Ocrevus for like 2 years now or 1.5 years, and during her pregnancy she gets a relapse of MS. So how do you handle that relapse? Just steroids only, or you use any kind of disease modifying treatment during or just after delivery in postpartum period?
Okay.
That's the
Yeah. So in terms of pregnancy, now generally imaging-wise, MRI during pregnancy is not absolutely contraindicated, but the gadolinium so far, the answer is yes. This is one. Number two, if we detect that clinical attack, whether clinically or radiologically confirmed, then and at the beginning, of course, like any case, we'll start the methylprednisolone to just decreasing those active activity or disease activity in the acute phase. Now, there is a talk about to start the interferon while the patient is pregnant or while the patient is lactating. Now, generally, it depends on the attack. Like if it is a sensory attack, we'll give the methylpred and no need to go further, because most of the pregnant ladies, they don't want to take any medication during their pregnancy. This is the wish of them all. However, we just explain everything, and we need to have our own also impression. So the sensory attack, I would not go further for any DMTs like interferons. Now, if the attacks, unfortunately, spinal cord or brains, anything infratentorial, let's put it this way, anything infratentorial, then yes, we'll give them methylpred, and we need to start here on interferon.
Hi, Dr. Rumaiza. Thank you for the nice talk. I have to ask one question. It's about your practice in your center. When do you think there is treatment failure? After how many new T2 lesions or how many relapses do you consider switching of the therapy?
Thank you so much. Now, the whole idea, once we diagnose and start medication, zero activity, zero lesion, zero clinical attacks, zero. Now, is it the case in every patient that we see? Of course not. But I would tell you, when I told the patient or myself that this is a treatment failure, we need to complete 1 year. This is timing or duration that before that it will be unwise to tell the patient or to yourself to decide that your patient is failed. One, because we are dealing with the immune system. Two, we need to give the patient and the medication the time to work. We all know that some of the medications, including fingolimod, the S1Ps in general, it will take 4 to 6 months to start their activity. Even the dimethyl fumarate, which I like in the beginning because it has those anti-inflammatory effect. So those big lesions and active lesions with gadolinium will subside all the way on. So yeah, for me, we diagnose, we start the medication, we'll wait for 6 months, right? Ask the patient if anything that they deal with to make them uncommitted to their medication. This is very important. Sometimes patients have gastric upset, like dimethyl fumarate. She cannot, the flushing effect, the hair loss. So a lot of things that she started to face, we really need to be vigilant because this will affect our management plan. We're not underestimating anything that the patient tell, because in the future, this will be also affecting our plan. So generally, I would say 6 months, and we'll do the MRI. Even if you see some few lesions are still active, don't worry. Just buy time and give it another 6 months. After 1 year, if there is a clinical, for instance, deterioration, let's say, or if you have MRI that's still active, this is the time where you need to rethink. Like, it's a red flag. If you start the right patient at the right time with the right medication, and you still have after 1 year disease activity, whether clinically, whether radiologically, then this is a red flag. We need to reconsider everything from the start.
Thank you very much, Dr. Rumaiza, for an excellent talk and a refresher. Our next speaker would be Professor Ugur from Turkey. They're going to be talking about new advancements in multiple sclerosis treatment. Over to Professor Ugur.
Good afternoon to everyone from Turkey. First of all, I would like to thank organizing committee for giving me the opportunity to present this topic. My objective during this talk will be understanding the new treatments through cases. But before that, let me start with a question. What has changed in MS over time? 3 things have changed. The first one, diagnostic criteria. The second, clinical predictors. And the third one is that there are more effective treatments in the MS field right now. What are these treatments in multiple sclerosis? So, personalized or individualized treatment in treatment by patients. Start treatment according to the risk predicted factors at onset with an escalation approach or with an induction approach, either with the intermediate potent MS treatments available or with the most potent MS treatments available. What is the escalation treatment? What is the definition of escalation treatment? This is traditional approach. Start with first line disease modifying treatment and escalate to the next step, the second line, and so on. Whenever new disease activity, critical or and by imaging, is detected. So even there are lots of treatment options in multiple sclerosis and new developing treatment options, why MS treatment is still so difficult. Although that we know quite a good deal what happens in MS, we still don't know the essential, the cause of multiple sclerosis. Of what we know, we also have learned that there's a wide discordance in the biology, pathology, imaging, and clinical phenotypes in MS. And all available treatments mainly affecting the anti-inflammatory side of the multiple sclerosis, and currently we don't have treatments for neurodegeneration. And finally, what comes first is the unchangeable rule: is the every individual is unique in multiple sclerosis. What about the guidelines? Of course, guidelines are important, but guidelines cannot replace critical thinking or dampen individualization of patient care. Since clinical practice guidelines should be data-driven as far as possible, they are limited by the data available. So how can we classify the multiple sclerosis drugs based on their efficacy and safety profile? First line, second line, third line, and fourth line, we can classify them. The first line treatment options mostly having immunomodulatory effects, group A interferons and glutaminyl acetate, group B teriflunomide and dimethyl group C that we are not currently using in the MS as a terpene and methotrexate. Second-line treatment options have also immunosuppressive effect, fingolimod, scronimod, cladribine. Third-line treatment options have immunomodulatory and immunosuppressive effect, natalizumab, alemtuzumab, ocrelizumab, and rituximab. And the fourth-line treatment options are mitoxantrone and cyclophosphamide. And meantime, we don't use these drugs in MS treatment. So what is the immunobiology of active MS? It starts with the autoreactive lymphocytes in lymphatic organs and then gets through the circulation and then differentiate and then proliferate and then pass through the blood-CNS barrier, evokes cellular response and then humoral response, and then damage to myelin, oligodendrocytes, and the other mechanism is repair. The repair can still continue in the inactive period in multiple sclerosis. So what about the drugs in the pathophysiology and immunobiology of active MS? Mitoxantrone for autoreactive lymphocytes and for the circulating lymphocytes, fingolimod for the autoreactive, glutaminyl acetate, steroids and interferon, the plasma exchange and natalizumab for the barrier of the lymphocytes passing through the central nervous system, and also B-cell depleted monoclonal antibody for diffusing the cellular response, and for the humoral response, and little effect on the repair mechanism. So, but the trials are, that trials regarding the repair mechanisms failed, and none of the drugs are approved by FDA for the repair of multiple sclerosis. Let's turn back to our case with EDSS4 and then respond to plasma exchange. This case might be accepted as highly active disease or aggressive MS. So the question arises that what is the definition of aggressive MS or highly active disease? There is still no consensus about the definite diagnosis or definite definition for aggressive MS, but there are some clues about the definition. For example, EDSS4 in the first 5 years from disease onset might be accepted as aggressive MS. 2 or more poor recovery from lapses following disease onset, active or T2 enlarging lesions and or contrast enhancing lesions, or more than 2 MRIs despite treatment, and unresponsive to 1 or more DMDs for at least 1 year. So, depending on the trials regarding efficacy and safety, we decided to start ocrelizumab. What are the results of these trials? If you will look at the trials, there is consensus on high efficacy therapy for patients with poor prognosis, and also high efficacy therapy given if prognostic factors predict poor outcome. Meantime, the treatment approach started to change. Nowadays, we are offering our patients induction therapy instead of escalation therapy in order to not to lose time for the future. So what are the results of the trial for high efficacy and the early treatment of the induction treatment? There are reports of coming from the trials for 7-year data from the OPERA study, which the ocrelizumab started in naive patients. Baseline characteristics were similar between treatment arms in the treatment naive and earlier relapsing multiple sclerosis subgroup. For 7 years, patients receiving continuous ocrelizumab treatment showed sustained benefits to 24 weeks, confirmed disability progression outcomes versus interferon to switching to ocrelizumab patient. During the ocrelizumab treatment, similar rates of progression were observed between patients who switched to or continued ocrelizumab. Over 7 years of treatment, the safety profile of patients was similar to that of the ocrelizumab all exposure population, with a reduced rate of serious infections. Rates of infections were lower in patients treated with ocrelizumab versus interferon, and remained low during the ocrelizumab, and remaining similar to rates in ocrelizumab all exposure population during the same period. So conventionally, relapsing and progressive forms of MS were accepted as different phenotypes, but currently we are knowing that relapsing and progressive forms of MS are overlapping phenotypes. So we should start the treatment as soon as possible in patients who have unfavorable clinical factors and who have MRIs showing poor prognostic factors. Then, but the second question arises right now: if the first line or the drug, the second line drug fails, what should we do? When and how to switch these treatments in multiple sclerosis? So there are three parts of decision for switching the treatment: drug-centered, patient-centered, and provider-centered. In the drug-centered part, the efficacy, safety, tolerability, and antibody development is important. The second part, adherence, pregnancy planning, and comorbid diseases are important. And the third one is probably the most important one in Pakistan and in Turkey as well: drug availability, infusion capability, and provider familiarity. So let's start with the first one, the drug-centered one, and let's focus on the efficacy, safety, and tolerability of the drugs. So what are the biomarkers for treatment success? There are three biomarkers: clinical, MRI, and laboratory markers. However, we cannot still predict the tailored treatment response, and we cannot predict which patient will have benefit from the drug on the long term. We need personalized biomarkers for the long-term treatments. So what is the definition of non-responders? There's no consensus about that, but there are some studies for trying to define the non-responders. Short midterm studies, 1 to 6 years. They published that the 1 point increase in EDSS within 6 months might be a good predictive of non-responders, and long-term studies which was coming from the Nature Restorative Disease, EDSS 6 and transition to secondary progressive phase, but in other studies increased EDSS or frequent relapses, increased frequency of attacks compared to pre-treatment, and active MRI during treatment. So how can we measure the treatment success? Increasing disability, attack frequency, and active MRI. New or enlarged T2 lesions or enhancing lesions. So the concept arises right now with these measurements. NIDA, no evidence of disease activity. What are we knowing about the NIDA concept? DAF, disease activity free, no evidence of disease or minimal residual disease. These concepts are coming from the oncology, which corresponds to cancer free or disease activity free, but unless we have biomarkers, we cannot say that there is no evidence of disease activity. So we need biomarkers to talk about this term clearly after having biomarkers on the long term. So what is the definition of cure, NIDA, 15 years, or benign MS? This is still controversial, the term of benign MS. And there are also new concepts. NIDA4 atrophy is included in NIDA4 and NIDA5 neurofilament light chain. So at the meantime, in our institution, we are requesting neurofilament light chain at the beginning of the disease to maybe we have a chance to predict the future of the patient together with the clinical activity and then with the MRI activity. This is kind of a helpful tool, but not mainly gives us the prognosis of the patient. So the other term is NEPAT, no evidence of progression or active disease. So there were three main aspects: clinical, MRI, and relapse. But now the neurofilament light chain and brain volume loss are added to NIDA concept. But how about the other complaints of the patients other than EDSS? For example, cognitive status, neurophysiological findings, or retinal structures, OCT. We are detecting some abnormalities at OCT in progressive MS patients, and also the patient self-report results. And we don't have any evidence or sufficient, let me say, sufficient evidence for spinal cord imaging for determining the progressive phase of the disease. So let me go through with the cases for giving a clue about switching the treatments in multiple sclerosis. Case 1, 44-year-old woman, she was presented with numbness in the right lower extremity, clumsiness, frequent urination, and inability to urinate after 2 weeks. This is the first MRI of the patient. You are seeing the brainstem lesions at the level of palms, and subcortical lesions, and juxtacortical lesions, and also tumefactive lesions in the right side, and most of them having contrast enhancement also at the level of C4, C3 to C4, on the left side of the cervical spinal cord, we are seeing a lesion. This patient was treated with IV methylprednisolone in another center in Turkey, and moderate recovery was obtained after the treatment. And at the time of the complaints, she was given teriflunomide. So it might be reasonable to start with teriflunomide as a first-line treatment option. But when we look at the patient's age, the relapse type, and moderate recovery from relapses, and adding the MRI prognostic features such as brainstem lesion, spinal cord lesion, and contrast enhancing lesion, we don't feel very comfortable for the future with less effective drugs. A year later, she was presented with a new relapse processed with a brainstem lesion, speech disorder, and a blurred vision, and also new lesion, tumefactive lesion on the left side. And she was admitted to our center after a year. With EDSS 3.5, we have observed increasement of the T2 lesions and also multiple gadolinium enhancing lesions, and we stopped teriflunomide and started with higher with the ocrelizumab with the higher efficient treatment in multiple sclerosis. So why did we change the treatment? Is there any consensus for changing the treatment? There is no established criteria for switching to treatments, but there are some reports. This report is very well written and giving information for switching the treatment. So 3 aspects: relapses, disabled progression, and MRI activity. So if the patient has more than 1 relapse in the first year of the treatment, and also severe relapses and incomplete recovery at 6 months with functional impairment, this might be accounted as a high active disease, and we should consider to change the treatment. And on the disabled progression part, more than 2 points at 6 months, if the EDSS is below 3.5, and more than 1 point at 6 months if the EDSS is between 4 and 5, and if the EDSS is larger than 5.5, 0.5 points at 6 months will be accepted as highly active MS. So the other score is RIO, the evolution of treatment response, and the 3 main aspects in this score as well: MRI, relapse, and EDSS. If the score is 0 or 1, it is accepted as responders, and if the score is 2 or 3, it is counted as non-responders, and then we should change the treatment after this scores. So what were the factors affecting prognosis? Gender, male, spinal cord syndrome, poor recovery from the first relapse, short duration between first and second relapse, and frequent relapse between 2 year and 5th year, and high EDSS within 5 years. So this will be published within a month in Multiple Sclerosis and Related Disorders journal. We analyzed the pediatric onset multiple sclerosis, 332 patients. What we have found is that multifocal involvement more in the group with treatment change. All of the results are consistent with the literature on the pediatric side as well. Spinal cord involvement more in the group with treatment change. And then in the treatment change group, the age at the first attack was younger and the duration of the disease was longer. And in multiple analysis, we have detected that spinal cord involvement and younger age at first attack were significant in terms of treatment change. So these are the clinical predictors for treatment change. What are the predictive factors of MRI? So we should focus on the smoldering plaques in multiple sclerosis to better understand the MRI activity in multiple sclerosis patients. So new MRI technique using 7 Tesla allow prospective tracking of smoldering chronic active lesions with notable darkened rims in people with MS. And over time, rim lesions did not shrink slowly as other lesions generally do, but typically remain stable or even enlarged due to ongoing demyelination. And this process has been linked to disabled accumulation. So we usually think that younger people have more active disease, but these 2 studies suggest that just because someone is older, they should still be watched closely. So what about the progressive MS? What are the clues in MRI for the progression of the disease? There's no established MRI biomarker, but spinal cord MRI may help us to comment about progressive disease in the patients, and particularly at the level of C7 to C6 to C7, if there is a volume loss at the level of C6, and you can measure it by manually the axial section of the MRI. This might predict the progression of the patients independent of clinical activity. I would highly suggest to read this paper for diagnosis of progressive multiple sclerosis from the imaging perspective. For the primary progressive MS, diffuse signal abnormalities in the spinal cord lesions involving gray matter and at least 2 white matter, atrophy of the lower portion of the cervical spinal cord. And for the secondary progressive multiple sclerosis, spinal cord lesions involving the gray matter and at least 2 white matter cones, and also atrophy of the lower proportion of the cervical spinal cord. So you might measure the spinal cord volume, and you might follow up the patient by the MRIs, whether the patient has turning to the progressive phase over time. So what are the other imaging hints for progressive MS? Lesion location, cerebellar lesion volume predicts transition to secondary progressive MS. Active T2 lesions, new or enlarging T2 lesions are associated with increased risk of EDSS progression, and development of new T2 lesions over 15 months period is predictive of long-term disability and brain volume loss. Gray matter atrophy and deep gray matter atrophy are also mentioned in this paper, which might help us to predict our patient whether turning to progressive phase or not. Other part is biomarkers, laboratory biomarkers. In our center, we are detecting plasma neurofilament light change. It might be a helpful tool if we combine the neurofilament light chain with clinical predictors and MRI predictors for determining the progressive MS. And also the other one is serum glial fibrillar acidic protein might correlate with multiple sclerosis disease severity. So this was the first part for switching the treatment, the part drug-centered. And the second one is patient-centered, pregnancy planning, adherence, and comorbid diseases. So I'm going to present the 2 cases regarding this part. 30 years old woman, she was presented with clumsiness, diplopia, numbness of both upper and lower extremity. Cranial MRI was suggestive of multiple sclerosis. She was treated in another center with IV metronidazole for 5 days, and 80% improvement was obtained after the treatment. 3 months later, a new MRI was performed to patient, and a new lesion was detected. So the first-line treatment was started at that time, 2011. However, 2 years later, the patient had active lesions at MRI, and the treatment switched to fingolimod, effective than the interferon beta 1b. So 5 years later, the MRI of the patients, we're seeing the periventricular lesion, subcortical lesions, and brainstem lesion, and T1 hyperintense lesions, T1 black holes, and also spinal cord lesion. So let's answer the question of timing of brain MRI protocol in patients diagnosed with MS based on this case. If the patient has no previous imaging available, for example, with follow-up from another clinic center, at the postpartum period, especially at the second month of postpartum, before starting or switching therapy, we should request MRI, and after starting the disease-modifying therapy, depending on the drug efficacy onset time. And then every 1 or 2 years during the treatment to assess subclinical disease